Our PLRP project is Predictive Pharmacokinetic and Pharmacodynamic Modeling in Oncology. I'm Joseph with Ashkan, Firas, Raul, and Jimee. Our mentor is Dr. Stephanie Zhao. Glioblastoma multiforme, GBM, represents the most malignant primary brain tumor in adults with generally dismal prognosis, very limited response to therapies, short median survival, and a high mortality rate. Current treatment involves complex invasive surgery followed by chemotherapy and radiation. Oftentimes, treatment is limited by the tumor location and the ability of a patient to tolerate therapy. In this regard, there is a desperate, unmet need for targeted treatment of GBM with minimum damage to the surrounding normal tissue. Sunitinib is a small molecule that inhibits VEGFRs, FLT1, PDGFR alpha and beta, c-KIT, the FLT3, and RET kinases. Previous studies by Dr. Zhao have demonstrated that the effect of sunitinib on the brain tumor distribution of temozolomide was dose dependent, suggesting that sunitinib dosage needs to be adjusted in order to achieve optimal tumor exposure in the brain. In this project, we sought to use quantitative pharmacokinetic and pharmacodynamics to evaluate the potential of sunitinib for the treatment of GBM.
The overall objective of our research project is to develop a predictive pharmacokinetic and pharmacodynamic model with the potential of translating non-clinical data to the clinic for the anti-angiogenic agent sunitinib. The long-term goal is to provide a quantitative basis to guide the optimization of sunitinib dosing regimen for the treatment of glioblastoma multiforme. Our first specific aim is to develop a preclinical PKPD model to better delineate the complex relationship between drug concentrations in plasma and tumor tissues, and to relate the pharmacokinetic profile to pharmacodynamic endpoints. Our second specific aim is to use the derived PKPD model to probe how various physiologic variables in dosing schedules may affect tumor response in humans.
An in vitro study was performed where in vitro cytotoxicity of sunitinib was examined in parental human U87mg glioma cells, PTEN overexpressing U87 cells, and EGFR8 mutant U87 cells using the sulforohodamide B or SRB assay. The growth of treated cells was expressed as a percentage of controlled cultures. The concentration of drugs that decreased the number of viable cells by 50%, also known as IC50, as compared to untreated cells was calculated by nonlinear fitting of the experimental data obtained from 3 independent experiments performed in quadruplicate. As a result, in vitro treatment with sunitinib showed differential cytotoxicity in parental U87mg, PTEN overexpression U87, and EGFR8 mutant U87 cell lines. The EGFR8 mutant U87 cell line showed a lower IC50, meaning lower concentrations were needed to decrease the number of viable cells by 50%, showing an overall greater efficacy. Given the fact that the in vitro cytotoxic effects of sunitinib was concentration dependent, it is suggested that pharmacokinetics should be integrated into the strategy of optimizing treatment regimens for patients with glioblastoma multiforme who are likely to respond to sunitinib treatment.
The in vivo study was conducted in athemic nude mice bearing U87mg brain tumor. Animals were given 40 mg per kilogram sunitinib via oral gavage. Following the oral administration of sunitinib, animals were euthanized at different time points. Sunitinib concentrations were measured in plasma, brain tumor, and normal brain using a validated LC-MS assay method. A sequential approach was used to develop physiologically based pharmacokinetic models of sunitinib in individual animals. In the first step, a compartmental model was fit to the observed plasma sunitinib concentration time data in each animal using maximum likelihood optimization. The resultant best fit models were then cast as forcing functions that describe the plasma sunitinib concentration input into brain tumor and normal brain. Each brain region can be defined by one or more compartments. Once again, the maximum likelihood optimization procedure is used to select the best fit compartmental model for each brain region.
Sunitinib plasma concentration time profile was fitted into a 2-compartment open model with first-order absorption and first-order elimination. The plasma model used in the combined plasma tissue model is a one-compartment open model with first-order absorption and first-order elimination. The reason that a reduced plasma PK was used was that the full model was unable to converge. The inability to use full model for the combined plasma and tumor model was due to the insufficient concentration time data points, suggesting a more comprehensive in vivo pharmacokinetic study needs to be performed in order to characterize the disposition process in the brain compartment in detail. Simulation can be conducted based on the model presented in the previous figures by varying the values of physiological parameters such as blood flow rate in brain tumors. Most published preclinical pharmacokinetic studies focus on plasma drug concentration measurements, which are assumed to be correlated with drug concentrations at the site of action and may be subsequently linked to pharmacodynamic responses. However, for anti-cancer drugs, such a relationship may not be straightforward due to the complexity and heterogeneity of tumor vasculature that often hampers the drug delivery from plasma to tumor. In this regard, we chose to incorporate sunitinib tumor concentrations into the disposition kinetic model, as this should be more indicative of drug concentrations at the target site given the VEGFR and PDGFR are located on the surface of tumor cells. Given the current molecular targeted therapeutic regimens are highly empirical in terms of the optimal dose and schedule for the anti-angiogenic agent administered, greater knowledge of the PK and PD of anti-angiogenic therapy is crucial to the clinical success of this treatment strategy for GBM. Moreover, the translational pharmacokinetic and pharmacodynamics approach explored in this project has demonstrated how preclinical and clinical research may be bridged to hasten drug development and provide an enhanced insight into the relationships between preclinical and clinical studies. Thank you.